there is concern that the facts that we have, the data that we have, aren't painting a complete holistic picture of how wide this outbreak is. Your sense from your experience of how accurate that count seems to be?
Well, it's certainly an undercount. The case numbers when they announced the outbreak just over a week ago were just under 250. Now that's pushing 800 in the official count. But for cases to go up that quickly, that's not new transmission. That's just beginning to get a sense of how much is already out there. And I don't think we fully have that sense yet. There's not a full contact tracing and case finding operation underway yet. And so there is still a lot out there that we're not seeing. I'm sure it's over 1,000 cases by now. It could be multiples of that. This is already on paper the third largest outbreak in history. It's well on its way probably to becoming the second largest given the trajectory that it's on. And I think it's going to be exceptionally difficult to contain.
I know when you're trying to fight an outbreak, you're fighting not just a disease, but you're also fighting misinformation and disinformation. And talk to us a little bit about how hard that battle is as well, because I was reading about this crowd that set fire to one of the few functioning hospitals that treats Ebola specifically in the eastern DRC, and partially that was because there was mishandling. They didn't understand why they couldn't have the body back. There's an issue with burial customs where they're washing the bodies and then that water is being passed around and it's easy transmission. How do you fight this on two fronts, especially when you're short-staffed?
It's such an important point, and it's easy to get caught in this idea that we just need a health response, we just need clinics. Secretary Rubio has talked about setting up 50 health clinics, and like the health clinic piece of this is important. It's also really difficult to scale, and of course you need, for those clinics to mean anything, people need to have confidence that they can use them. They have to have confidence and trust that they will get treatment that the treatment that they need, and that they understand that that's what they need to do. And that all really comes down to trust. And so an outbreak response, the foundation of an effective outbreak response is trust between the communities who are at risk and the health responses, or the operational and health response itself. And we saw this the last time there was a major outbreak of Ebola in eastern Congo. That was in 2018-19. That was the second largest in history after the West Africa one that I worked on in 2014. And we saw these kinds of patterns. It's not surprising to me that people our community members are behaving this way, because they haven't, they don't understand the disease. They're not necessarily familiar with it. They don't necessarily believe everything they're being told. There's a lot of skepticism. This is a part of the country that has been affected by war for decades, that is often quite hostile towards the central government. And so when they have the Ministry of Health from the central government telling them something, they won't necessarily take that at face value. So that's going to be a huge hill to climb.
Jeremy, I want to ask you about the role that the U.S. is playing or isn't playing at this point in time. So we've seen the U.S., as Christina mentioned, withdraw from the WHO, not playing an active role in that organization any longer. I mentioned in the last hour, we were talking to our colleague Jason Gale, who covers public health, that we've both been kind of inundated with emails from the State Department over the course of this last week detailing what the U.S. has done here, noting that the CDC is running point here, and saying that the overarching objective here is to keep Ebola from coming into the United States. How different is the response posture from the U.S. this time around than what you lived through in 2014? Jason Gale mentioning to us that Tom Frieden, who ran the CDC, said that the Ebola outbreak was a full-time job back when he was in that position. And here we're in a position where a lot of these marquee positions in the public health apparatus in the U.S. are unfilled or filled by interim appointments.
Yeah, and Dr. Frieden and I worked very closely together on that response. We actually, early in the U.S. response, traveled out there together to Liberia to assess firsthand and to meet with the president of the country. There is just dramatically less capacity in the U.S. government to tackle a challenge like this than there was even 2 years ago. We had learned a lot of lessons from that 2014 Ebola outbreak. At that time, of course, USAID existed. There was a very robust CDC. We were a member of the World Health Organization. And all of those things were really important. USAID, CDC, and WHO worked together hand in glove to lead the international response to that outbreak, and then reprise that again in the large outbreak in the same area of eastern Congo, or in 2018-19. And that's mostly gone now, that partnership. CDC is a shell of what it was, particularly their global capabilities have really been degraded. They're still there. I mean, look, the people are excellent. The people have tremendous knowledge, but will they be listened to by the people running U.S. health institutions right now? That's a big question. USAID, of course, is completely gone, and the U.S. is no longer a member of WHO, and often CDC staff are barred from even speaking to WHO. So that partnership has been just demolished.
I want to read some statements, as David mentioned, we've been getting from the State Department, saying it's false to claim that USAID reform has negatively impacted our ability to respond to Ebola. In fact, by bringing USAID global health functions under a new bureau at the State Department, our efforts are more aligned and effective. You also mentioned on Tuesday, the State Department announced they'd be funding these 50 clinics to aid in the DRC, but the top civil servant in Uganda's Ministry of Health said in an interview that the government was not aware of the pledge, and it wasn't immediately clear where those $13 million were part of, where that pledge was going, or where those clinics were being set up. Where is the breakdown there? Is this something that would usually happen through WHO, these organizations? What is the line of communication? And is this something you can just stand up, or does this need logistics and things on the ground that, as we've talked about, don't really exist?
Yeah, I really am disheartened by that whole exchange, because you see a few things there. First, so it was my job in 2014 to oversee the planning and development and funding of about 30 Ebola treatment units that we stood up across West Africa in that outbreak. Those things were wildly expensive. It cost us hundreds of millions of dollars to stand up and operate those things. So $13 million is barely a start to what it's going to cost to get this under control. But I think they're hugely complex. It took us months to stand those up, because Ebola clinics are highly specialized facilities, because they are built around very high-end infection prevention and control, because you don't want to enable more transmission. It's the whole point of those facilities. They're very different from a normal health clinic and very difficult to set up. But really importantly, we did all that in close partnership with the ministries of health in the countries we were working with. And the last thing we would have ever wanted to do is catch them off guard with an announcement we hadn't discussed with them first and didn't have their buy-in on. So to see that sort of an exchange between the U.S. Secretary of State and one of the affected governments just, I think, speaks to the lack of coordination, the lack of engagement between the U.S. and those governments. And again, that's the sort of function that USAID would have facilitated, because there were deep webs of relationships between the USAID health personnel in those countries and their counterparts in ministries of health. And of course, that's all gone now.
Jeremy, let me ask you, as we wrap up here, how worried you are just about the circumstances that we're seeing in Africa right now. This is a different strain than we've seen before. There isn't a treatment for it. As you said, the numbers seem to be undercounts of what's likely the case there in the DRC. How concerned are you about the state of things now and where they're likely to go? And can you say unequivocally that without having USAID, without having the public health apparatus in place that we've had in the past, that's likely to make this outbreak much worse?
It's going to make the response much harder. And when you have a slower and less effective response, of course, the outbreak lasts for longer and it spreads further. And ultimately, a delayed or underpowered response just makes the ultimate job of containment harder, more expensive, more difficult. It will take longer. I fear that's what we're going to see. We're going into this with four strikes against us. This outbreak has the most momentum upon discovery of any Ebola outbreak in history. It's in eastern Congo, which is a conflict zone with 3.5 million displaced people. And we know from the 2018-19 outbreak, it's very, very hard to fight Ebola under those conditions. That one took 2 years to get under control. There are no countermeasures and no vaccine for this, unlike the normal Ebola, not normal, but the other kind of main Ebola strain that we've seen, which is the Zaire version. And of course, we're doing this without USAID, without the US being part of WHO, and with a weakened CDC. So all of those things are going to make this job much harder.